We've talked a lot over the last day or so about genetics and biology and so on. But I'm actually going to talk about what children ask me in clinic. So when children come to clinic, and we see about 450, 500 children a year, they want to know about treatment and they want to know how they're going to get better. And actually studying that's really difficult. So I'm just going to walk you through a variety of methods that we've used working with children and their parents to try and improve treatment and treatment outcomes in this important condition. So I'm going to talk about the importance of chronic fatigue syndrome, the problems that we face in trials, and then some of our results. And I'm going to talk to you about our current trial and our new trial that we're going to start recruiting for in about a month's time. So you don't need me to tell you that chronic fatigue syndrome is important. In children, it's very common, and it's also very disabling. And it has a really big impact in terms of both the child, the family, loss of earnings for the family, and societal costs in terms of high health resource use costs. Now, I'm sure all of you have looked at the posters, but if you haven't, you should go and have a look at Simon's paper. This is data from just last week, which shows that years before a child develops chronic fatigue syndrome, they're going to see the GP more often, they're getting more prescriptions, they're getting more tests. So this is a costly illness at societal level, family level, and for the child themselves. Now the problem as a clinician is that we have guidance, this is NICE guidance, that tells us what we should provide, and for children coming to my service, we have to provide CBT, we have to provide graded exercise therapy and activity management. And all I'm going to say is that there's good evidence for CBT in paediatric chronic fatigue syndrome, but there's currently no evidence for graded exercise therapy or activity management in terms of randomized controlled trials. The other really big problem in paediatric chronic fatigue syndrome is there's very little service provision in the UK. So this very white map that has not projected very well, what you can see is that there's some service provision in the south. My son did this map for me. He knows my favourite colour is yellow, so I just worked that out. That's why it's yellow. We are the local providers for Wiltshire, Somerset and Gloucester, but you can see for most of the UK there is no specialist service if you're a child with chronic fatigue syndrome. Now, so those are the problems that we have. And the other problem is that to design trials, and Sarah's a great introduction, we need better patient-reported outcome measures. So our papers showed that that none of the outcome measures that are currently used have actually got any face validity in children, which means that children were not involved in the design of those outcome measures. And even if we did have outcome measures, we've no idea how much change is actually important for patients. And this is such a simple question, isn't it? Every child asks me this, and almost every parent asks me this. Is my kid going to get better? And if they are, when? And we can't answer that question, we've got no idea. We don't even know how to define recovery. Actually, recovery is a really interesting concept. It's a sort of, is recovery when you go to school full time? Is recovery when you feel better? What does recovery actually mean? We don't even know how to define recovery. So these are questions that are really important to the children that come to my clinic, and they're also important to clinicians, and they're also important to researchers. So my kind of research program, in addition to the MRC work that I talked about yesterday, and the work we'd like to do on the genetics and so on, a lot of it's based around trials, and these are some of the things we're going to talk about. You've already heard about the systematic review on patient-reported outcome measures. Sarah talked about that. I'm going to show you some data on recovery, and then I'm going to talk you through some of the ways that we have been using to try and understand how we can better measure outcome and how we can answer some of these questions. Okay, so we've done a systematic review, it's not yet published, looking at every trial, prospective study and epidemiological study which actually had a measure of recovery in paediatric chronic fatigue syndrome. And the first thing that you realise when you look at this is it's an absolute mess. So some trials use a single measure such as school attendance or fatigue, some use multiple measures, and probably the most robust ones use a composite measure to define recovery. So fatigue has to be normal, and disability has to be normal, and there has to be full-time school attendance, and the child has to say, I'm actually better. So actually trying to collect all that data is very complicated, but there is a relatively simple message at the end of it, which is that, does this have a pointer?
Yes, top one.
Okay, so basically if you look at the green trials, these are the proportion of the green dots, these are the proportion of children who recover with treatment, here, using different methods of describing treatment, and the red dots are the ones without treatment. So the message that we say to commissioners who fund services is that children who have access to specialist treatment have, on average, when you look at the data, a more than 60% chance of recovery using a variety of different methods to define it at 6 months. And that compares to less than 20%, and in fact in the largest trial, the FitNet trial, 8% recovery without treatment. Okay, so this is different to adult chronic fatigue syndrome because children with chronic fatigue syndrome are much more likely to recover than adults. And the reasons for that are really interesting. We don't know why, but they are. It'd be really interesting to find out. But importantly, if children don't have access to treatment, their chance of spontaneous recovery is very low. So I think we have an obligation to provide children with specialist treatment. We then went further and we have actually interviewed children and parents on how they would define recovery. I was interested in what they thought about it, and I thought that they'd tell us how to do it. This is the hardest study that we've done, in fact. Children really didn't want to talk to us about recovery because it made them so depressed how ill they were. And parents found it very difficult to conceptualise their child being better, and children and parents who had recovered and moved on didn't want to talk to us about how bad the illness was. So we haven't really got very good answers for this in terms of the interviews and the children. My view at the moment is that we should either use a combined score or have a single question on recovery. So, because the other thing is that children will say, well, I'll know I'm recovered when I'm doing sport, or I'll know I'm recovered when I go back to school, or I'll know I'm recovered when I feel okay. And actually for each child, the concept of recovery is probably going to be different. So at the moment, I think that we should probably, in addition to all the other outcomes, ask a single question on, are you recovered or not? Okay, so this is one of my PhD students, Roxanne's work, developing a new patient-reported outcome measure. For those of you who think this is easy, this has taken over 3 years, and we're not quite there yet, and I'm going to tell you about the process and the results. Okay, so when you're developing an outcome measure, you need to understand how patients conceptualise the illness, then you define the domains that are important to them, and then you develop the questions. And we used a variety of approaches, but mainly interviews with patients, children, their parents, and we used a patient advisory group to take our ideas back and refine them. And I have to say, our patient advisory group was brilliant. And when we got really stuck, they unstuck us, so that was great. So children have a conceptual model for chronic fatigue syndrome, which is actually different to clinicians. So children are very consistent. You have chronic fatigue syndrome and you feel terrible. That gives you a whole load of symptoms. That reduces your physical activity and your social participation, and that then has an effect on your well-being. And it's very linear, one to the other. And behind this, and you'll see this later on, there is this fluctuation which goes up and down, and there's how people engage with you at school and other conceptual factors. So it's very, I'm sick, and it has these outcomes. Clinicians don't think like that. Clinicians tend to think it's actually more complicated, and that each thing leads into the other with the conceptual factors around the edge. So in fact, the first thing to say is that children's model for this illness and professionals' model for this illness are not the same. So when you're actually interviewing children about factors that are important to them, you get a huge number of domains that they want measuring. Interestingly, no child ever said they wanted biological measures. Isn't that interesting? They were given a free choice to say what they wanted measured. These are the things they'd come up with. And actually trying to get that into a questionnaire that is not going to take them 2 hours to complete was quite difficult. So we developed some different methods to try and do this. So we had all the different outcomes that are important, and we used something called card ranking, which we haven't seen used for patient-reported outcome measures in children, certainly, to actually try and understand which were the ones that were the most important for us to measure. And we repeated a whole load of interviews with children and parents. And the results were really interesting. So here is a girl, age 15, with CFSME. Top thing that she wants us to measure is symptoms. Second thing, fluctuation. They want us to measure the degree of fluctuation, the degree of payback, the instability of the condition. Now, this is where you've got to go to patients, because it wouldn't have occurred to me to measure that. And her mum is different. They're more interested in mood and self-esteem and factors that they see protective. And you can see there are differences between the children and the parents that are some of them are the same. So on the whole, most parents want us to measure symptoms, and tiredness is fairly universal, but there are also differences. And there are differences between boys and girls as well. So symptoms are more important to girls, activities and hobbies to boys. So there are differences between the gender, and there are differences in age as well. So mood is more important for the older teenagers, and family and what's happened to the family more important to the younger children. When we were doing it, we learned quite a lot about this illness, and you can see that you can use some of the card ranking to actually prompt for questions. It's like they're always there, and on a bad day they get worse. And that enables you to develop some of the questionnaires, some of the questions that we used. I think being able to do a certain activity, if I'm doing it for longer or having more energy to be able to do it. So this taps into some of the problems in terms of measurement. Are you actually going to measure how many activities a child can do, or how long they can do it, or how frequently? So it's quite complicated. I like this one. I can try and get rid of the symptoms, and then I can get into school, and then I can see my friends. That's why symptoms are so important. And this is our final conceptual model with the domains and the areas that we ask questions about. So the prom is finished. It's going into the final testing phase. This is what it looks like. We've designed it to be completed online. Almost all our questionnaires at assessment and outcome questionnaires are all completed online these days. That's what children want, so that's what we do. And you can see these are the different domains: hobbies and leisure, friends and family, fatigue, symptoms. So what about the actual outcome measures that we're already using? So this is the minimum clinically important difference idea. And what we're trying to do here is to understand, so quite a lot of people have presented results in terms of statistical significance. What we're interested in is the change that we're measuring actually important to patients? And there are three ways you can do this. You can do a consensus method, an anchor method, and interviews, and we've done all three. So consensus method would be a range of professionals around a table who make a decision on behalf of the patients about what change is actually important. The anchor method, so we have a question in our outcome measures that asks about improvement. So you can actually measure, I'm a little bit better or very much better, and then see what outcome measure, how much the outcome measure you're interested in changes. So you can do that. Now, we were quite interested in the SF36 because patients tell us out of all the measures we're using, it's one of the ones they actually like, surprisingly, even with the question of golf in it. So the anchor method will tell you that the minimally clinically important difference is about 10, and the consensus method says 10. But we then went and interviewed children and asked them how much change would actually be worthwhile having treatment for, and the answer is somewhere between 10 and 15. So actually, when you go to children, they want more change than the other methods suggest. So I think when you're thinking about designing a trial or doing a trial, you just have to think about these questions about how much change is actually worthwhile for patients, not just what you're going to find and be able to publish. Okay, so you can see on this diagram here that this is all stuff that leads towards a trial. Systematic review, what change is important, how do you define recovery, and this is leading in to our trial, the Magenta Trial. So the Magenta Trial was designed to investigate the effectiveness and cost effectiveness for graded exercise therapy in children. It has a feasibility phase which is just completed and has integrated quality methods. This means that all the way through the trial we've been talking to children, parents and clinicians about the interventions and trial processes. Why? NICE recommends that we should offer GET to children, but there are no trials in children to show that it's effective. And in my clinic, GET's very popular. Children and teenagers like it. They ask for it, they want it, they prefer it to a lot of the other methods, but we don't know how to deliver it, and I can't hand on heart recommend it everywhere without being absolutely certain that it's effective. So in Magenta, all children get offered advice on symptom control, sleep and medication. The aim of both treatment arms is to convert the boom-bust cycle, children going to school loads one day and then not the next, or doing PE one day and not the next, to a stable baseline and then increasing it. And in the activity management arm, we're really focusing on, we're working on all activity that the child does. But for most teenagers, that's mainly going to be cognitive activity. So that's mainly going to be schoolwork, reading, socialising, screen time, laptop, TV, games, and so on. So that's most of what they're going to be working on. In the graded exercise therapy arm, it's really a detailed assessment of physical activity, and then we use the boom-bust method, but mainly focusing on physical activity. So you are going to school on 3 days a week, and when you go to school you play football, and on the other 2 you're in bed. So what we want to do is even out, so you're not doing loads of football on one day and none on the next, and even it out so you're doing the same every day. But really just thinking about the physical activity portion of the day, not the whole day. And I thought I'd like to share with you what children think about it. There is lots of negative press about graded exercise therapy, but actually our experience has been very different to what you might read about it. So the first thing to say is that children and their parents like both arms. Here are some quotes about activity management. Can you guys read that at the back? You can't? No. Okay, I'd hate reading out quotes. Yeah, because like at the start of the trial I was like really ill, but now that I've reduced a lot of stuff I still am ill, but I'm not as ill physically as I would be. And the mum, oh, it's great, yeah, I think it's good, I mean it's a way forward, it's how you found out, what is the way to improve, it's definitely useful. So here are the quotes on GET. I was expecting it to be really scary, they wouldn't understand what I was talking about and what I had. It's like they understand what you have. You can pace yourself with it, and you don't have to do it all in one go. It helped me push through and get there, getting back with my friends. Because I'd been away and off school for so long, because I was really ill. When I got back, I couldn't find anyone who wanted to be my friend. I've got my friends back. Okay, I've just picked the top quotes. I haven't actually chosen any of them. They've been very flexible because I'm trying to play a little bit of netball each week, and with other things I think it's been helpful. And what was I saying? I think the daily walks, I wasn't quite expecting that, but I think it's been really good for me. I think it's been really good. It's stopped me being quite as lethargic, getting out every day, definitely. And yeah, my fitness has improved, which has made just normal walking around a bit easier, I think, and less tiresome. So I think that's a real positive. Yeah. I definitely haven't got the adolescent tone right. I'll work on it. Can you read that one? It's a bit bigger. It's been really flexible to meet his needs. The exercise initially was increased because he could cope with that at the time, and it's decreased with, his needs changed, and because he was coping with other things as well. And so the exercise has decreased to allow for that at the moment, and I'm very confident that when we go back, ex-clinician will listen to everything he says and, change it accordingly and appropriately, really. Oh, and we do have a complaint, but the complaint is not the way that people talk about it on the internet. So in all our areas, people complain about reduction on exercise. So with GET and with activity management and with all the strategies we use, normally the first thing we do is reduce what they're doing. And I just love this little exchange. Participant, I don't like the level. Mum, no, she wasn't happy. Participant, no, it's not good. Mum, ballet is one of her things. That's her number one thing that she loves more than anything in life. And she's had to cut back a lot on her ballet, which I didn't know they'd say that she'd had to do. And she's really not very happy about it. No, Mum, to put it mildly. So, you know, it is a horrible condition. People really suffer and they have to give up a lot. And often to begin with, we cut back on exercise, establish a baseline, and then gradually increase it up. But this is the only negative about GET that we've had, is that we're reducing exercise, not increasing it. I like this one, stuck to it. This is empowering a young person to say, I don't think I can do that, Mum. Okay, so where are we after a year? You heard yesterday that recruitment of 20 or 30% into trials is fine and is considered good. We've had very good recruitment into this trial. Treatment is acceptable, patients like both treatment arms and they're sticking with the treatment. Retention is good, follow-up is excellent. We've done our data safety monitoring committee report. There's been no evidence of harm. There is also a lot of data that I have not got, which basically talks about how much teenagers value being part of a research trial. They really want to help. Teenagers are much more altruistic than grown-ups, and they want to help people in the future, and they want better treatment for people in 10 years' time, and they really enjoy being part of the trial. Okay, I've got a couple more minutes left. So this is our new trial that's starting recruiting in November, FitNet NHS. It's an HTA-funded trial. Okay, this is the map of the UK again. It really disturbs me that so many children do not have access to local specialist treatment. And what this means for me in clinic is that I'll be sitting in my clinic in Bath and there'll be families that have travelled 4 or 5 hours each way, stayed in a hotel to come and see us for assessment. It's very difficult to assess children when they've travelled that far. The families are paying for their hotel and accommodation, and I have felt for a long time that I wanted treatment that could be delivered locally. So FitNet was published, most of you will have read it, in the Lancet a few years ago by Sana and others, and the acronym is there. And it showed very convincingly that about 63% of children were fully recovered at 6 months versus 8% in the standard medical care arm. Okay, really, really extraordinary treatment effect size. And we thought that this may be a way of getting treatment to children throughout the UK. So this is our referral pathway. We already see children referred from GPs over the UK. They'll go through eligibility assessment, and then if they want to go into the trial, they'll be randomised to either activity management, which will be delivered by Skype, or FitNet, which will be delivered online. It's powered, it's a very, very large trial. We'll be analysing data from 660 children, so this will be the largest trial ever conducted in chronic fatigue syndrome, adults or children. And this is what it looks like. So it's a really nice platform. Children have been involved all the way through. Interestingly, they like something that's quite formal. They don't want all the kind of colours and so on. And it uses a variety of techniques of diaries, a whole range of different diaries. The consultations are done by e-message, and there's a lot of information about chronic fatigue syndrome. One of the very interesting things about FitNet is that the parents do modules alongside the children. So the parents are learning about chronic fatigue syndrome and how to improve your sleep and so on, as the children are as well. These are some of the diaries. So, I think I'm on time. In this talk, I've talked about how important chronic fatigue syndrome is, emerging evidence on increasing healthcare use, the problems that we face at a very real level in terms of developing treatments for chronic fatigue syndrome. I've briefly told you about our results in recovery, our new patient-reported outcome measure, the difference between what patients think and important increases compared to researchers, our Magenta Trial, and FitNet. I'd just like to remind you that most of this work was done by my team and not by me, and the patient-reported outcome measure was done by Roxanne here, which is a lot of the work I've described. Thank you very much.
We have got time for 2 quick questions. If you'd like to raise your hand, we've got one in the middle. Okay, thank you.
Yeah, Esther, thank you. I read recently a paper from Peter Rowe's group in the United States, who does a lot of pediatric work on neuromuscular strain in adolescent and pediatric patients, and how that did not help or was hurtful in certain instances. Do you get to comment on this a little bit, or have any insights on that work?
Well, I haven't read this paper, but so was he commenting on it in the use of exercise, or?
So they tried to mimic exercise in certain ways, using what they call neuromuscular strain. And the results were not positive in terms of the improvement. In fact, they saw a regression in the overall activity level and capacity. So I thought, I think maybe we can discuss that after later. But I wanted to know your insights on this, and if.
So I think understanding the biology is going to be really important, isn't it? But the reason why we do trials is actually that we want to improve treatment for children. And given the evidence in adults that it can be helpful, and given the fact that children want it in my clinic, and my view is that we need to actually see how we can actually deliver a treatment in the UK that's actually going to, and see whether it's helpful for children or not. And then I think one of the things that's going to be really interesting is that, going back to this stratification question. So are there a group of people that are actually going to find exercise much more of a problem than other people, mainly adults, but also in children? And how can we actually detect that? And one of the ideas that we talked Neha touched on briefly earlier is that maybe what we can do, so the outcome in children is great compared to adults, so 66%, 60%, much, much better than in adults. That still means that 40% of children are not getting better at 6 months, or not fully recovered at 6 months. So one of the future directions, I think, is you take ideas like that in the context of very large trials like Magenta, and actually look at the children that have recovered and don't recover and see if there are differences between them, so we can target our treatments more effectively, so that in 10 years' time we can say to someone that comes in, look, well, like we do with leukemia, you have this particular type of chronic fatigue syndrome, and therefore this type of approach is going to be most effective for you.
Yes, I think my question feeds into that. I'm just wondering whether the response was something to do with the level of severity of the ME/CFS that the people who participated started with. Because, for example, some people can't actually go to a baseline when they don't have symptoms. If they're very severe, they're not going to have a baseline, basically. And maybe, the people who were having this neuromuscular strain were more severe than maybe the people who you see who are able to up their exercise, because going to school even 2 or 3 days a week seems like quite a lot to me, from my personal experience.
Yeah, so these are children that are well enough to attend clinics, so they're mild to moderately affected. I think the really interesting thing about Magenta and the quotes and what we've seen, and Magenta includes accelerometer data, so we've actually measured physical activity on everybody in both arms. So, and I can tell you that there is a wide range of physical activity that teenagers are doing. Some are doing very little and some are doing a lot. But the important thing is actually, there are no patients that were, to begin with, it's all about decreasing and evening it out. And actually that's a principle that we can't all sign up to. So, if you are actually doing football 3 days a week, and then in bed the next 3 days a week, we need to even it out. And I think it's often about decreasing, not increasing, particularly at the beginning.
Thank you, Esther. I'm sorry we haven't got more time for questions now, but if there is at the end, we will come back to it. So whilst our next speaker gets mic'd up, for me, this is a real big area of concern. Severely affected CFSME patients, children, young people, are a widely misunderstood and ignored group, both clinically and in enabling them to participate in research. So it's with real enthusiasm we welcome Victoria to the platform. And very kindly, Julia told me a little bit about her. Victoria is a chartered physiotherapist who has a background in working in neurorehab. She joined the Newcastle Fatigue Cresta Clinic as a novice to fatigue in research in 2013 and has looked at fatigue from the background of the neuro-rehab and the impact of gravity since she began in the clinic. She now works in the Cresta 1 session a week and for the rest of the time has been heading up a project to define the prevalence of severe ME in the northern region. We cannot learn too much about this group, so thank you. Over to you.
Thank you. So thank you for asking me to speak, and thank you to ME Research UK who funded this project to understand the clinical characteristics of the severe CFS group and its relationship with cognitive and autonomic dysfunction. This group we looked at were the severely affected as defined by the Diane Cox descriptors, so housebound, wheelchair bound and bedbound. And that's the descriptions that have come through in the NICE guidelines in the CMO report from 2002. These patients were over 18 with self-reported CFS-ME. The aims of the project were to define the prevalence in the Northern Clinical Network area, to explore the quality of life and symptom burden in this patient group, and to determine the clinical characteristics of those with severe CFS-ME and are they generalisable to the more general CFS-ME population, based a little bit on the previous MRC project that Julia mentioned yesterday. And then finally to consider this relationship between autonomic dysfunction and problems with depression, memory and concentration. It was a 2-phase project. So the first phase was to create a database so we could understand the prevalence, and then the second was to then select 5 people from the database for us to go out and visit. So this is the geographically defined area, all the way up to the Scottish borders, over to North Cumbria, not South Cumbria, and then down into sort of North Yorkshire area. And then I did my air hunter bit and I went on the census from 2011 and worked out how many people are in that area. So we're looking at about just over 2.5 million in the Northern Clinical Network. If the statistics are right and 0.4% of them have CFS-ME, we're looking at just over 10,000 people. If the statistics are right again and 25% are predicted to have the severely affected expression of CFS-ME, then we're looking at just over 2,500 people that we needed to connect with. So I connected with 63. So this is how we went about doing it. So we advertised via the Northern Clinical Network services, GP practices, local and national charities, and through the CFS-ME Facebook website through the Newcastle University, and the advert went up. And as I'm sure you're aware, with research you cannot approach people, they have to approach you. So people would contact the website, they would say, please can you send us a pack? We'd send a questionnaire pack out with the expression of interest, patient information sheet, and then 3 questionnaires, demographics, a DePaul questionnaire, and then also a Bartel questionnaire. And we sent out 58 questionnaires and received 38 back by about Christmas last year, and we thought this is just going too slowly. So then we approached ME North East, who were really helpful, and said, where are we going wrong? And they said, well, it's just too much information. They have to contact you, then you have to contact them, and it's just too much for them. So we went back and put a substantial amendment in through ethics and asked, can we put together 425 packs, give them to ME North East, and can then they just mail shop them? Because we couldn't get hold of the addresses of those patients because we're not allowed to see, they have to approach us. So again, it's one of these obstacles I think is going to have to be looked at in the future if this kind of research is going to happen in this patient group. It needs to be either more relaxed, or we need to find a way of waiving some of the consent issues. So we sent out 425 packs and we got 25 back. So we now have 63 data sets in various phases of completion. So this is the information that's come back from Bartel. So we've got 48 returned from Bartel, mean score of between 14 and 15, a range of between 5 and 20. 12 is a pivotal cut-off point in the Bartel. So if you score 12 or less, you are dependent. So 30% of the people who returned are dependent on somebody else for their personal care and their mobility. Scoring 17 suggests that you need help for activities of daily living. So 67% scored 17 or less there. Now, the Bartel is used quite a lot in stroke outcome measures, but it has been used in the severely affected group in the past. The DePaul symptom questionnaire looks at, because there's there's variance in the descriptors, it takes descriptions and dimensions from CFS-ME and then applies them and then can work out which diagnostic criteria you fit into. So it looks at clinical Canadian criteria, it looks at ME international consensus criteria, and it looks at the FACUDA criteria. It's quite a hefty questionnaire to fill in, 54 symptoms on a Likert scale. One of the issues I suspect was that patients just could not complete it. They were too severe to complete this. So this is, I suspect we're looking at the less severe expression of the severely affected. So what we saw was 60% fulfilled both the CUDA and the Canadian criteria. 18% fulfilled either or, but 22% didn't fulfill either. So this suggests that 40% of the patient group possibly need further investigations to get a definitive diagnosis. And this is quite, I found that's really interesting when I went through everybody's demographics and I counted up how many different how many conditions were in their past medical history. I got 65 different conditions. In the presenting conditions, excluding CFS-ME, I got 16. There are so many different comorbidities present here. And these patients believe they have CFS-ME, but we don't know what the overlap is. So we then selected 5 patients to go out and visit. So just to give you an idea of how well they were able to participate, of those 5 patients, 60% completed all of the visits. 2 were only able to complete 75% of visits. So what that basically means is 2 of them were either too poorly during the course of the 3-month sessions that we took, the 3-month length of time, in order to complete all of all of the home visits. And one of them had to decline on the day because she was unwell on the day. So they wanted to be involved, and as far as they could, they tried really hard to be involved. And then these here are how we broke down the visits. So the first of the visits was to the consent procedure, and then the autonomic testing. We went out with a nurse that day, and she helped me do that. Visit 2 was the neurocognitive testing. Visit 3 was semi-structured interviews, and then the final visit was physio, bit of physio, little bit of assessment, physical assessment, feasibility into what could we ask patients to do, what were they able to do. So for the most part, in visit 1, everything was completed or attempted. One participant refused to do part of it, which was fair enough. I think she probably wasn't well enough to do it. And I probably would have made a clinical judgment not to do that particular test with her. That particular patient also refused to do the neurocognitive test, and again, just as Esther said, it was just too upsetting to realise where you were. And then she said, you leave me and then I'll be left here. Fair enough. She'd be left with those feelings and nobody to talk it through with. So that was a clinical judgment. No, she wasn't going to do it, and that's perfectly all right. The semi-structured interviews, very, very keen to tell me their stories. They wanted me to understand. They want the world to understand where they're up to, their progression, how they've got to this place. So we've got a lot of qualitative information. And then finally, the information, 2 of the patients in visit 4 just weren't able to manage that day. And participant 4 was unable to do an awful lot of that. What's interesting is participant 4 and 5 both live with parents, so they could complete everything. They had quite a supported home network, so they had the resources there. So they were able to be involved and to do what we needed them to do. So all in all, they were really proactive. They really wanted to be there. They were completely engaged with the process as far as they could be physically. So I've got more questions than answers now. So confirmation of the diagnosis of the third of the patients would be really interesting and I think valuable to know. Are we looking at what we think we're looking at? More investment into accessing those with severely affected CFS-ME. We almost need an advocate to help them through. If we gave them questionnaires, they were able to complete questionnaires, but I suspect we weren't getting to the whole remit, the whole spectrum. The more severe expression, people who have withdrawn from sensation, from vision, from auditory, those people who just cannot cope to be in a room, to have somebody else in the room, how do we contact them, how do we communicate with them? And we've got ideas and things we could look at, but what can we do? Early stage identification of those individuals who may be susceptible to the severe expression, for education, symptom management. So are there risk factors in this population group that we could identify and think, right, you'll want to watch the way they do in other areas? So we can come up with some kind of prevention, management and maintenance process so that we can give people education. Like, just watch out for these things, do this. Quite simple things that need to do. Explore the rehabilitation environment in context of the International Classification of Function and Disability. Disability isn't just a single entity, it's all these different interactions, and we still don't understand what's going on. What resources are in the home, what resources do they have personally. That all needs to be looked at and investigated further. Specific rehabilitation towards reconditioning against the force of gravity. The bedbound, a lot of them, being bedbound is a microgravity environment that has physiological consequences in itself. What are we doing to address that, to educate people about how to avoid being bedbound for any length of time, other areas to rest in, other environments to rest in, specialist equipment that could be taken so that they can try and avoid some of these processes. And then finally, explore the possibility that this group fits into a complex disability category, so the category A, sort of complex disabilities, where there's category A facilities in the community, in facilities where people visit, but what about those resources being mobile and being accessible in home environments? So is that a possibility there? So thank you very much, and thank you to ME Research UK.